Good afternoon, everybody. And as anticipated, there are just few surgeons. I think only a couple of or three surgeons. So it would be not very interesting for the other people. But I would just be talking about the basics of operating microscopes and more about physics of it. So all the microscopes that we work on have a stereoscopic vision. That is, now what is the stereoscopic vision? Now all of us know that what is stereopsis? It is primarily when we look at anything. So say for instance, you are looking at me, or you are looking at the screen. We're looking with the help of two eyeballs, and this slight difference in the angle at which the eyeballs they look at each other, or sorry, they look at a particular thing. Now, this difference in the angle is perceived by the brain, and it merges those two images into one functional image, and that is why you see one object. But because of that, what happens is you are able to perceive the depth of a given object, and that is what is known as the stereopsis. And that microscope and that vision is known as stereoscopic vision, and the microscope which provides the 3D vision is known as the stereoscopic vision. Okay, or stereoscopic microscope. Now, this is important because in the later slide I will talk about endoscope also. Now, the problem with endoscope shall be that the endoscope only provides you a 2D image, and that is a major limiting factor for endoscope. That is why we prefer microscope over endoscope in any of the surgeries, unless it is a minimally invasive surgery or in which only a small corridor is needed. So, for majority of the surgeries, majority of the surgeons, be it endocrine surgery or be it plastic surgery, ENT surgery, whichever surgery you name, they prefer microscope over endoscope because of the 3D vision or the 3D perception that the microscope provides to us. Now, why do we need microscope? We can operate with bare eyes also, but then it provides us with certain distinct advantages. Definitely, it provides us with magnification. Now, how is that important to us? It provides us not only the accuracy. Say, for instance, the middle cerebral artery, which is a branch of the internal carotid artery, it is only 4 or 5 millimeter in diameter. Now, if you have to anastomose a middle cerebral artery, or if you have to operate upon a middle cerebral artery, it is extremely difficult to operate upon such a tiny structure with bare eyes. Now, when we use a microscope, that single vessel is enlarged to about 20 times or 18 times or 6 times, depending upon the surgery that we need to do. And so we can see the vessel better, we can operate upon that minute structure better. Now, it will not only increases the efficacy, it increases the safety, it increases the precision of our surgery. Apart from that, the hand-eye coordination of the surgeon is very important in such a case, because you are looking in front, but you are operating down below. I don't know whether any ophthalmic surgeon is there or not. They shall understand this thing very important, that because when you are looking in front and you are operating down below, you need a very particular amount of hand-eye coordination, and that is why when we finish our case and we hand over the microscope to our senior resident, we ask them to just suture the skin or the dura under microscope, so that we can develop that hand-eye coordination for your future surgical skills. Now, this is a typical microscope, operating microscope that is present, and these microscopes are multi-purpose. They can be used by ENT surgeons, by ophthalmologists, by urologists, by endocrine surgeons. The basic concepts of any of the microscope is primarily the same. Now, if you see here, this is the very bulky body that it has, and this is the arm, and this is the optical part of the microscope. Now, this optical part of the microscope is enlarged here. Now, this is the surgeon eyepiece through which the main operating surgeon would be looking at, and this is the observer eyepiece through which the assistant shall be looking at. Now, this is actually changeable. We can put it here also. This is just a simple lid, and it is an empty cavity out here. We can remove the observer part and place the observer part here, and similarly on the other side. Now, why is this important? Depends upon what surgery we are performing, whether it is a right side tumor present is in the right side or tumor is present on the left side. Depending upon the location of the tumor, we have to change the eyepiece so that the surgeon and the assistant can well accommodate each other. Apart from that, you can see that this is a screen out here. These are the components which are present in any of the microscopes. So this is the large screen, and this is primarily used for the persons who are observing the surgery from outside, that is for not scrub, and also more importantly for the scrub nurse, because it is the scrub nurse who shall be seeing the screen and anticipating that which instrument has to be given, what are the likely things that we shall be needing in the next step or in the subsequent steps. These are the handles that the microscope has. It has two handles. Now, one of the important function that you can understand is to move the microscope from one angle to another. But apart from that, you can see there are multiple small buttons out here, and you can see buttons out here. Now, the two most important functions of the microscope are to focus and to magnify. So these buttons primarily provide for magnification, for zooming, dezooming, and to focus near and focus for distant objects. Now, apart from that, it is a customizable thing. You can change the settings. You can start the recording in the microscope, you can stop the recording in a microscope, you can take a screenshot, you can transmit it to the TV screen, whatever you want to do, you can customize these settings. You can shift the microscope a little bit. I'm not sure whether you are available to see or not, but there's a small joystick out here. It has 4 directions, up, down, right, left. So you can move the microscope to some extent by using this joystick as well. Now, there are primarily 2 types of microscope that are used. One is the ceiling mounted and one is the floor stand. Now, floor stand is the one which is far more commonly used, and as you can see, but the floor stand has certain distinct advantages and certain distinct disadvantages. The advantages, as you know, is first of all, it is very easily mobile. You can move it from not only from one corner of the OT to another corner of the OT, you can move it from one OT to another OT as well. Say for instance, you have, like, neurosurgery department has 4 to 5 OTs. So if a microscope malfunctions in one OT, we can simply move this because it has tires downline. So we can easily move it from one OT to another OT. The second good thing about the floor microscope is you can change the position of the microscope, and you can easily, the working angle of the microscope is pretty good. But the problem is this is a very bulky microscope, and in operation theaters which are relatively small in size, it actually, the staff, the surgeon, they feel cramped because of the presence of such a large bulky thing in the operation theater. The second problem with this is, whenever you are using this microscope, say for instance you have a lead which has to be connected to a TV screen so that the observers who are present in the OT, they can see the surgery. The lead has to be plugged in and plugged out every time you use a microscope. So what happens is, and these microscopes are very delicate things, even if a single pin breaks, then the entire outlet function becomes disabled. The advantage of ceiling mounted is, because it is ceiling mounted, nothing needs to be done. It is hanging out there. You just have to switch one on, and you just have to press one switch on, and then the microscope starts working. Just switch it off and the microscope stops working. So the entire wiring is inherently done. It is inside the walls. The problem with ceiling mounted is, apart from non-mobility, is it gives you a limited degree of freedom. If it is wall mounted, and if I want to move the microscope to a larger degree, I cannot do that. So that becomes a limited, and it is very good for OT which are usually smaller in size, because if it is a smaller size OT, then first of all the floor mounted will occupy a large amount of space. Secondly, the ceiling mounted, you don't have that much of liberty of moving the microscope too much in a small OT. So in such a cases, it is good that you have a ceiling mounted microscope, but if you have a large space, then it is always preferable to have a floor mounted microscope. Now coming to the optics of it. Now before I start with the optics proper, just like to tell you a bit about the lenses out here. Now this is the Galilean telescope, and this is the Keplerian telescope. I'm sure you would be familiar with these names. This is named after Galileo, and this is after Kepler, and both of them were important people in the, as far as the field of astronomy were concerned, and they had used telescope extensively. Now before them, there was no system in which the magnification could be achieved properly. So what they did was, what Galileo did was, he used 2 lenses simultaneously at a particular distance so that he could see the image of an object enlarged. According to his words, he famously said that I can see a small fly as large as a hen. So that was the amount of magnification that he could achieve by using only 2 lenses. Now what they used to do is, they used to move these lenses either towards each other or away from each other to increase or decrease the magnification. And this is the Keplerian telescope. What he did was, he was able to achieve a larger magnification by using simple convex lens, both convex lenses. He used a concave and a convex lens. Now why is it important for us? In a given microscope, you have an objective lens, that is, which points towards the surgical field. Just assume that there is some brain out here, and then you have an eyepiece, and then you have a magnification changer. Now there are 2 lenses which are placed, and simply the magnification works on the same principle. What we do is, whenever we have to magnify an image or magnify an surgical field that we need to see, the distance between the 2 lenses is changed. That is all that happens. That is why I just wanted to tell you that how it is, and this system is known as a telescopic system, because the microscope or the 2 lenses will move one onto each other, either closer or farther, depending upon the range of magnification that we want to achieve. Sorry. Now you can see here, this is better described here. So this is a small specimen out here, and this is the objective lens, this is the ocular lens, and you can see a magnified image out here. Now magnification is one of the most important functions of any microscope that is used, and it depends primarily on 2 things. One is the focal length of the objective lens and the eyepiece, and also upon the distance between the 2 lenses. Now, there are ocular prostheses or ocular helps that provide fixed magnification, like with ENT surgeons and the plastic surgeons use, which are known as the loops. I don't know whether you have seen loops or not. It is simply a specs, and there are two lenses which are fit onto the glasses. But the problem with them is that it is a fixed magnification. It can magnify to 1.2 or 2 or 2.5 magnification maximum. The advantage of using macroscope is that the magnification can vary depending upon your need. The usual macroscopes that have the magnification limit of anywhere between 1x to 21x. That means it can enlarge the image to about 21 times. So what is a magnification changer? The magnification changer is, if you see in the previous image, this is the magnification changer here. What it does is you can change the magnification by two methods. One, there is a knob here. You just change the knob and the magnification will change. The other method is known as the motorized zoom technique. The handle that I showed, it has two buttons, one for the zoom and one for the de-zoom. You simply have to press that button and the image will zoom in, or the image will zoom out with the help of the other button. So that is known as a motorized system, but primarily what it does is it just moves the two lenses either close to each other or away from each other. Now there is concept known as the field of view. Now you have to understand that, say for instance in this auditorium, if you're sitting in one of the seats out there, in one of the corner, perhaps you will need only the lights on the right hand side of the auditorium. The lights on the left hand side of the auditorium might not be needed. If you have to light the entire auditorium, then you need much more light as compared to the light needed for a part of the auditorium. Now similarly, if the microscope is providing light to the entire area of the head that we need to operate upon, that is a wastage of light. Moreover, the light needed in the area of the surgery, of the area of interest, is reduced. So what it does is it uses the concept of field of view. So when a microscope is properly focused, what is the field of view? It is simply the diameter of the operative field, that is the area of interest. Say for instance, I have to operate upon the frontal lobe. So it will only focus on the frontal lobe. That is the field of vision. The rest part, as you can see here, will be blacked out. So the entire light that is being used is used only for the area of interest, and the area which is we are not interested in is blacked out. So that improves the optics, or that improves the illumination of the area that we want to operate upon. Now, why is it important? It is important because you have to understand that as we keep on increasing the magnification, because say for instance, I am operating upon a frontal lobe, but now I want to operate upon the smaller vessel like the anterior cerebral artery. Now that is a very narrow field. So because of which what happens, when you keep on increasing the magnification, the field of view keeps on reducing. And this is important because I shall just tell you in a couple of slides later. Okay, so the field of view is inversely proportional to the magnification. As the magnification increases, the field of view keeps on restricting, because our area of interest, our area of the area in which we are operating upon is becoming less and less. Now there is another concept known as the depth of field. Depth of field is important because, as I mentioned in my first slide, that ultimately the microscope provides a 3D perception. So therefore, what is the depth by which and to which the microscope can perceive the image? So that is known as the depth of field. And why is it important? Because similarly, until unless the microscope is able to provide the depth perception, it will not be able to give us a 3D feedback. And that is one of the main advantages of using the microscope. And just to explain it to you, just imagine you're looking at the chair for some time, and this is my chamber. So just focus on this chair. Say for instance, you're focusing on this chair. You know that there is a chair besides it. You know that there is a view box above it. You know that there is a cupboard on the right and the door on the left. So you have an entire 3D perception of the chair. You know that the chair is related to another chair. The chair is related to a view box above, the door on the right side, and the cupboard on the left side. But if you keep on zooming it, if you zoom it, and if now you're able to see only the chair. Now the 3D perception of the chair is, although it is visible, you know this is the vertical part and this is the horizontal part of the chair, but the 3D relationship of the chair with the surrounding is lost. If you further zoom it, this is approximately 7x. So if you further zoom it, you can see now you can hardly differentiate between the vertical and the horizontal part of it. And if you further zoom it, so that difference is also lost. So to understand, as you increase the level of magnification, your depth perception keeps on increasing. Now, anyone could ask that why not use a microscope with a maximum magnification? Why to have a range of magnification? It is always better to see the vessels large. It is always better to see the finer details larger. The problem is because the depth perception, if you increase the magnification, is lost. That is why whenever you use a microscope, you have to be very judicious to what magnification you need, what is your field of view, and what depth you want to operate upon. That is why we don't use 21x in all the surgeries. We use it in only for limited number of surgeries, in that too for a limited period of time. Now there is a concept of autofocus in the microscope, in the recent microscope. What it does, it identifies the area of interest and then it autofocuses on the particular area. But the problem with this is, it is very good technique, or is a very good innovation as far as the superficial part of the surgery is concerned. If you want to operate upon, if the field of view is large, if you want to operate upon the superficial surface, say for instance you want to operate upon the surface of the frontal lobe, then this is a very good technique because it is a large area, it will focus upon that. But if you have to work on a depth, then and you are working in a magnified field, the problem with this microscope, this technique is, or technology is, what it does, it identifies it because 3D perception is lost when we magnify. Because the 3D perception is lost, what it does, it identifies the superficial part of the brain as the area of interest, and it will keep on focusing on the superficial part of the brain because the 3D perception is lost when we magnify. It will always keep on focusing on the superficial part, and the part in the deep part of the brain is always lost. So in such case, when you have to work on high magnification in depth of in any part of the body, then what we do is we usually switch off the autofocus mode. Now this is the principle that I was talking about, the 3D principle. So basically the microscope provides a 3D magnified visual image of the binocular image. But the important thing is that you should know the interpupil distance. Now, the interpupil distance is extremely important, because if you are unable, as I shall show in future slides, if you are unable to move the eyepiece together and it does not fit into your interpupil distance, then it shall become extremely difficult for you to operate upon a surgery. Now then comes the intensity of the light. Now intensity of the light primarily depends upon the objective lens, that how much light it is allowing to pass through it, and also depends upon the field of view. As you can understand, this, for instance, there is a 10-watt bulb and it has to light the entire room. It shall be very faint light all around the room. But if it is a 1000-watt lamp, then perhaps the room would be much better lit. So similarly, the light intensity will depend upon the diameter and the field of view, that is the area of interest. Now why is it important is, as you keep on increasing the magnification, the area of illumination is reduced. Now how does it work? You have to understand that majority of the lamps, the microscopes, they use xenon light, which is a very it is quite hot it has a very high level of thermal energy to it. Now if we use a very high intensity of light, it is calculated in percentages like 10%, 20%, 30%. Normally we work in 30 to 50% of intensity of the light. We never use 100% intensity of light, because if you use 100% intensity of light, then chances of thermal injuries to the structures of the surgical field are pretty high. So to counter that, what we do is we usually keep it at 30 to 50%. That is usually more than sufficient. Now, as I told you earlier, when you magnify, your field of view becomes narrower. As it becomes narrower, if the intensity of the light is same, then the chances of injuring to the neural structure or to the vascular structure will be pretty high. So to compensate for that, what the machine does is, as soon as you keep on increasing your magnification, the intensity of the light will reduce. So what happens is, although there is a manual override to it, if we still want that we have to know we need a 50-60% intensity of light, we can still go and increase the light. But the machine will usually reduce the intensity of light if you increase the level of magnification. And this is another reason why we don't use high magnification, because if you use very high magnification and if you increase intensity of light, chances of injury to the various nerves and the vessels will be pretty high. Then there is a concept known as the beam splitter. Now what is a beam splitter? See, there is just one object that is the area of interest, and there is just one light that is coming from the being reflected from this area of interest. But then what happens is, there is an assistant port that is, the assistant also has to see. Then there is a video camera there is a video recording system that has to be recorded. There is another screen in which the nurse has to watch. there are multiple TVs also that the observers who have to watch. So how do we do that? So we use the concept of beam splitting. Beam splitting means a single ray of light shall come here, percentage of it will be transmitted through it, and a percentage of it will be reflected out here. So you can see here, we are looking at a particular thing. So the video camera, it is going to the video camera, 30% of it is going to the video camera and 70% of it is going to the assistant port. So many times what happens is the assistant will always see slightly darker as compared to the primary operating surgeon, and the reason is because of the beam splitting. Now the beam splitting can be used for video camera, can be used for TV, can be used for recording purposes, can be used for anything. But it basically what it does, it just splits the beam in whatever percentage you want. Now this is the eyepiece that I was talking about. Now this eyepiece has various focal lengths to it, so that many of us are wearing specs. Some might have minus 0.5, some might have plus 1.5, whatever is your power. So you can use these eyepieces in two ways. One, either you can take off your specs. There's a knob out there. You can just adjust your power, say for instance minus 1.5 or plus 1.5, whatever it is your power. You can just adjust that eyepiece out there, and then you can view it. Or the other way around is you can just keep on wearing your specs and keep the eyepiece centered at 0. Normally, like when I operate upon, I just keep the eyepiece centered at 0 and I use my specs. But it is an individual decision. Many people, they take off their specs because they want to keep the eyes just adjacent to the eyepiece. But it is a personal choice, but you can use it either way. Apart from that, it is very important. You can see a mark here and there's some marks out here. Now what are these marks? These are marks for the measurement of the interpupillary distance. You ask any neurosurgery resident or a faculty or ophthalmologic surgeon or an ENT surgeon or a plastic surgeon, whoever are using microscope, they would be knowing what is their interpupillary distance. Because if it is not there, say for instance, on the left eye the eyepiece is fitting, but on the right eye it is slightly less, it is slightly more medially. So what will happen? The left eye will look straight into the eyepiece, but the right eye has to slightly deviate medially. Now when that happens, the gaze of the eyeball is lost. When that is lost, the brain will never perceive the two images as one. So people will always see two images. Now that is problem for two reasons. First of all, you won't be able to operate properly because you are seeing a double vision. Secondly, it will ultimately lead to, for long surgery, it will lead to headache. Why it will lead to headache? Because the either medially or laterally, some muscles of the eyeball are acting extra as compared to the other muscles of the eyeball. So you will eventually develop headache. So it is it is very important that you keep your interpupillary distance, you know your interpupillary distance, and you maintain the eyepiece at that particular, and it is in millimeters, 64.5, 64.7. That is the level of accuracy that you need to know that where your eyepiece fits you. Now types of illumination, as I just mentioned, initially there were tungsten bulbs, halogen bulbs, but now we are using xenon bulbs. Now this is a 300 watt, but now the technology is using 400 watt bulb, and this is it has a pretty high level of thermal energy. And moreover, as I saw you, as you might have seen in the first slide, in which I showed you the Galilean telescope and the Keplerian telescope, both of them use convex lens as well. So what will happen is the large amount of thermal energy is being focused onto a particular point. So the chances of thermal energy increases in such cases. That is why there are all these mechanisms. Like we have the Leica microscope, they have a patented technology known as the bright eye care. Basically, it is nothing but when you zoom in, the intensity of light will just reduce, or when you take the microscope closer to the operating area, then the intensity of the microscope light will automatically reduce by itself. And this is present in almost all the good brands of microscopes. Now, initially when the microscopes were made, the light source used to be away from the objective lens, and this was the tissue with the wet surface. Why is it a wet surface? Primarily, the brain gets damaged if it is kept dry for a long period of time, so we keep on irrigating sign so that it remains wet. So with the tissue with wet surface, it becomes a good reflective area, and it will keep on reflecting the light. So say for instance, you are giving 100 units of light out here, 30 units of light will actually get reflected, and only 70 units of light will go into the objective lens through which the person would be visualizing it. To overcome that, what it was done was, the light source was placed here, and then another lens was placed here, and the light is reflected here, and this light is reflected back to the objective lens, and the person is viewed, and the person viewing his eye is somewhere here. Now this is known as the coaxial system. Okay, because the axis of the light, the incident ray, and the axis of the reflective ray is the same. because of which what has happened is even lesser degree of illumination will provide a better vision to the operating surgeon. This is known as the coaxial system. Now this is further of the coaxial system. Now see, coaxial systems works very well if it is a proper cavity. Proper cavity means if it is a spherical cavity or a square cavity, that is fine, but then that is never seen in an operative field. You always get irregular cavities. Say for instance the tumor has been removed here, and this is a very irregular cavity. So for the center part, the coaxial system will work very well because the lights will go here and they will reflect back into the eyeball. But what about the side areas? Moreover, what will happen is because the side areas are dark, they will cast a shadow onto the central area. So how do we overcome that? What do we do is we have an auxiliary illumination on the side. These are very small bulbs, but what they do is they just illuminate the lateral part or the hidden areas of the operative field, so that there is no shadow onto the main area. Apart from that, there is a concept known as the automatic light collimation. What it does is, it is a shutter or it is a door. Say for instance, there is a large door, this entire wall on the right side is an entire door, and you see thousands of people coming out here. So what do you do? How do you control it? You just close all the doors and just keep one door open, so that one person at a time will enter into the auditorium. So that is what this concept is. What it does, it just by artificial intelligence, it just identifies that what is the contour of the operating area, and then it keeps, there are multiple small shutters or diaphragm. It will just collimate itself in such a way that only the light falls onto the area of interest and not distributed around it. Now this is the stand. Stand is one of the most heaviest part of the, apart from the body, the second most heaviest part of the body of the microscope is the stand. Now you might remember from your studies in 7th or 8th standard, we used to study about the pulley, that a very heavy load can easily be lifted if we use a system of pulley, either one pulley or a double pulley system. Now this stand is pretty heavy. To move such a microscope would mean that enormous amount of energy every time a surgeon wants to move a microscope, and believe me, we keep on moving the microscope every 1 minute or 2 minutes. So definitely the surgeon would get tired. So how do they? But it is very easy. It is just a touch of a button. You just touch a button and you can move the entire handle or the stand of the microscope very easily. How it is done? It is done by providing a counterbalance weight out on the other side. Because it is balanced on the other side, what happens is the area or the objective lens or the optical part of the microscope appears to be very light. You can easily move it with a single hand with a single button. And whenever we need to balance the microscope, before any surgery we balance the microscope. Now you can always think that I need to balance the microscope every time. In the microscope I showed you, say for instance, the surgeon eyepiece is fixed. Say for instance, today I operated upon a patient who has a right-sided tumor. Tomorrow I am operating upon a patient who has a left-sided tumor. So when I was operating upon a patient who has a right-sided tumor, the assistant will stand on the right side. But when I am operating upon a left-sided tumor, the assistant might have to stand on the left side. So the eyepiece has to shift from one side to another side. And eyepiece is a pretty heavy thing. So when we move the eyepiece from one side to the other side, the microscope becomes disbalanced. So we have to balance the microscope every time we use this. We want to operate upon a patient. Even if you are operating upon 2 times a day, we still have to balance the microscope 2 times a day. So for that, what we use is, so what the microscope does is, it just redistributes the weight along this stand, so that the microscope feels, the stand and the optical part of it feels relatively weightless. Now there are various accessories to the microscope that we have nowadays. Some of them is the closed TV circuit. If you come to neurosurgery OT, then you can see that there are 2 large television screens, on I think 57-inch or 55-inch, 2 large TV screens attached in every OT that we have, attached to the microscope. So whatever we are seeing as surgeons, the observer who is standing there, who is not scrubbed into the OT, can also see the same thing on a large TV screen. So we have a closed TV circuiting, we have video recording system. This video recording system is apart from the video recording system in the microscope, because microscope has a limited capacity, 1 TB or 2 TB. And if you record, these are high definition microscopes. Sometimes they are full HD, and now even 4K microscopes are available. So if you record, if you operate 3-4 hours, then it becomes 60, 70, 80 GB storage capacity, and that cannot be kept on the microscope, because then the microscope eventually starts to hang, because this is ultimately a computer system. So we have a separate recording system. Then you have a co-observation point. Initially I told you that there is just one observation point, either the assistant can stand in front, on right or left, but now the microscopes have 2 viewing system. The surgeon can look at definitely he will be looking at the operating area, but apart from that there will be one port for the observer in front and one port for the observer on the right or the left side. So that is primarily done by beam splitting, but without compromising the intensity of the light. Apart from that, there is a concept known as the auto balance. Auto balance, what it does, after you change the port, observer port from the right side to the left side or to the center side, then you just have to click this button. You can see this dot here. This dot is brought to this blue box, and then you just press the auto balance button, and the computer or the microscope will redistribute the weight, and it will auto balance on itself. Now, various accessories have developed. Now, unfortunately, the video is not playing for me. There is a concept known as the indocyanine green angiography. What it does is, you can see here, this is an aneurysm, and this are the clips that have been applied. So what it does, it actually entirely blackouts the field of view. It becomes dead black when you start off with, and then this dye is injected, which is known as the ICG dye, indocyanine green dye, into the we ask and request the anesthetists to please push this dye about 20 ml or 10 ml or 5 ml depending upon the size of the age of the patient and size of the vessel that we intend to visualize. So once we do it, this vessel will become brilliantly white. So now we know that the vessel is patent after application of the clip, and we know that the aneurysm has been completely clipped. Similar technology is also used for tumor surgery, which is known as the 5-amino-levinoic acid. Now primarily it is I'm not going to the details of this technology. What it does is, the tumor cells, they produce a particular, they've taken this 5-ALA, and once they take up this 5-ALA, they can't process it further. It causes a protoporphyrin excess form. They can't process it further. So what happens is, with the help of a particular wavelength of light, it is reflected like this. So we know that the tumor is here and the rest of the brain parenchyma is normal. So we'll operate upon only the abnormal tissue of the brain and leave the normal tissue of the brain free. This another concept is the picture on picture, and all these facilities are available with us as well in the OT. So this is the picture in picture. You can, it is actually customizable. You can put any picture in picture. You can put a normal microscopic picture with an ICG. You can put an ICG picture enlarged with a normal picture of the microscope in a PIP. You can have fluorescein and ICG, whatever combination you want to operate upon. Say for instance, you want to operate upon a tumor which is very close to the major blood vessels in the brain. So what we use one normal, and then we keep another picture in the ALA, and then we shift on to the ICG mode in the picture in picture. So this is the customizable thing. You can choose what things you want in the larger screen, and what technology you want in the PIP image. There is another concept of neuronavigation. Now, neuronavigation, to understand, is primarily it works like the GPRS system. I'm sure all of you would be using the this Google. What is that known as? Rastra batata hai? Google Maps. So you would be using the Google Maps. So Google Maps basically works on the GPRS system. There are two satellites which send signals, and then because it is sending it at different angles, so it will pinpoint that where is SGPGI, because it is basically looking at two different angles. Similarly, in this neuronavigation, these are the two infrared cameras. It should just shoot images, shoot this infrared rays to a particular localizer, what will be known as a localizer, and then it will be able to tell you where exactly is the brain tumor, so that we can give a smaller incision, we can make a smaller craniotomy. Now this system can be easily integrated with the microscope. So just imagine you are operating upon a tumor. Here, say for instance, tumor, you are seeing the actual brain, you can see the actual tumor. But what happens is, when you superimpose the neuronavigation image, it will actually tell you how much tumor is left and how much tumor is to be taken off. So that actually gives a higher degree of accuracy, so that even 1 millimeter accurate, we can 1 millimeter accuracy can be there. We can take off the tumor from the tumor area without actually damaging the brain part of it. Now, sterilization, initially we used to use formalin tablets and formalin chambers, but now all our offers are using sterile trays. These are microscope specific trays. As you can see here, these are all sterile trays. It will drape till this stand, and so we can easily touch these handles and touch these eyepieces. Now, this actually does not increase the cost that much. It is about, I think, about 200 or 250 rupees one drape, and that is used for every surgery nowadays. So coming back to my initial slide. Now, the endoscope has certain advantages. You have to imagine the microscope is actually in placed outside the body. So we are using it. So what it is doing? It is providing the light from outside into the brain parenchyma or inside the skull base or inside the kidney, inside the eye, whatever is you're operating upon. What endoscope does is it takes the light source close to the area of interest. It is like a torch that you are using. Either you light up the entire chamber, or what you can do is you can use a torch to find where the lost pen is. So that is the thing that provides the endoscope. In the endoscope, the light is source is at the end of the endoscope. If there are any gastroenterologists, they would be knowing that how does an endoscope work. It is at the end of the tube. You take the tube closest to the vessel or the brain parenchyma, wherever you want to operate, it will go there and it will look into the corners. The problem is with it, it only provides a 2D image. So the depth perception is lost. Because the depth perception is lost, it becomes very difficult for us to understand that where exactly we are. So for small tumors, for limited number of surgeries, we can use endoscope. But for major surgeries, primarily we always prefer microscopes. And what this means with salvage difficult? Salvage difficult means it is bleeding. Because it is such a small light source, it immediately becomes clotted. Everything that we are red, you don't know from where the bleeding is occurring. So in such a case, we have to take out the endoscope, wash it again, and then again reintroduce it, and then it becomes the salvage for the patient becomes much more tougher. Now, ultimately, if you see, microscope provides a clear stereoscopic view. It has ample of homogeneous illumination because of various accessory lights, various other technologies that are used. Then you can have interchangeable. Then you can have interchangeable lens. You have variable magnification. The magnification of the microscope ranges from 0.4x to 21x. It is a because of the technology, it is such a balanced structure, and moreover because of electromagnetic grips, it just holds on to the floor where you have placed it. You do not actually, you can't even move the microscope even if you use your full might because of the electromagnetic suction that they use. So it is extremely stable, well balanced movement, and now it is providing coaxial illumination. So illumination is very good, magnification is very good. All these things, they add on to your accuracy, your precision, and your good surgical outcome. Thank you. Yeah. See, picture in picture means this is one picture in another big picture. As I showed you, say first I am operating upon a blood vessel. Now I need this view because this is the view in which it is the natural view. I am seeing the artery as red, I am seeing the veins as blue, I am seeing the vein parenchyma as whitish red in color. This I need to see because I want to operate upon this patient. But if I want to find out whether this vessel has been compromised or not, I need to have a ICG dye. Sorry, if I put this entire picture only, if this is the only picture I am seeing, if I have to make corrections, then I cannot do that because I don't have this natural image with me. So what we do is, we use a picture-in-picture technology. So here I will have a normal image and here I will have a ICG. So I can see the normal image as well as I can see the dye in the normal blood vessel, and I can find out whether the blood vessel or the is compromised or not, whether the clip that I have applied is proper or not. Similarly for tumor, say for instance, this is the normal view and here I am using the aerial technique. Now I know what is the abnormal part. After seeing here, I can take out the tumor from this part of the intended part of the surgery. So it actually helps the surgeon to see both the images simultaneously. You wanted to ask something? Neuronal disease. Neuronal cell activation. See, that is what I was telling. The neuronal cell activation does not occur. The problem would occur is because this xenon light, already we were using 300 watt light, now we are using a 400 watt light. This has a very high amount of thermal energy. All the things that we have told you, that the field of view or the depth perception, the magnification, the illumination, all of these are done primarily to reduce the thermal energy to the brain parenchyma or to the eye or the ENT, whatever purpose you are using it. So what it does is, if you're using it for a very small area, so the illumination automatically comes down. For instance, if I'm working for 50 or 55% of illumination, if I zoom in, the light intensity will come down to 30%, because the field of view is reduced. It knows, the microscope knows that because I am interested in a very small part of the brain, the intensity of that would be very high for that part of the brain, and can lead to damage to, especially to the nerves and to the vessels. Normal brain parenchyma might actually escape the injury, but because the blood vessels and the nerves might actually get damaged. So what it does is, it automatically reduces the intensity of the light. That is why we never use 100% light intensity, and that is why we never use 21x magnification, because the injury to the brain parenchyma or to whatever surgery, for whatever surgery you are using it, might actually be pretty high. Thank you. No, ma'am, we have the floor. We have 5 OTs, so we have about 5 or 6 microscopes. So, ma'am, the advantage is that we have a very spacious OT, so we don't have that problem. In all the institutions, ma'am, they only have floor mounted. The ceiling mounted is usually in those areas which have a much more smaller OT area. So that actually saves space for them, because they have much more things that have to, because they have to have an anesthesia trolley, they have to have a nursing station, they have to have other gadgets that have to be used. So in those cases, they use a ceiling mounted. Majority of the centers, they have floor mounted. Ma'am, yes, ma'am. Robotic surgery is being done in neurosurgery also, but it is done only for very specific indications. Like, it's used for urology, and for endocrine surgery is pretty good, but for neurosurgery it is still in its infancy. It is still being developed. It is used for some specific, like taking biopsy, or for what we know as the DBS, gene based stimulation. Those parts can be done with robotic surgeries, but usually it has not become very active in neurosurgery as of now. Now, robot surgery, what it does, it, instead of us handling the microscope, we are sitting outside the operation theater, or we are sitting away from the patient, and we are manipulating the robotic arm through the robotic station that is there. So the surgery is primarily the same. That is what it is done is, if you have to take a biopsy, we mark the entire chart, the path through which the needle has to go. So the robot will go to that area, robotic arm will go to that area, and it will pass the needle to it. Complex surgeries cannot be done by robotic as of now. Thank you, ma'am.